This meeting is being recorded.
Well, hi, everybody. How you doing?
We're doing great.
Awesome. Welcome. So we're going to spend some time together today reviewing our spinal motion restriction guideline. And with us, we have a panel. First off, we're going to start with Jennifer Pagel, one of our field supervisors, Sam Rodriguez, our clinical educator, and Dr. Decker. And for those of you that haven't met me before, my name is Shevis. So why don't we review why we're revisiting spinal motion restriction today?
I'd like to tackle that question. So based on some CQI and chart reviews, we kind of identified some patients, multi-trauma patients that should have had spinal motion restriction implemented and had not. The good thing that we did discover is that none of those patients had any kind of bad effects of not having spinal motion restriction. And so when we implemented this protocol, I think our thought was that the pendulum had swung so far over to where we weren't immobilizing anyone, and there are certainly opportunities or times that we should use spinal motion restriction.
That makes good sense. So has there been a major edit to this guideline in the last year or so?
Sure, I'll tackle that one since I guess I'm responsible for editing the guidelines. No, we actually haven't edited this at all. We built the guideline, I want to say about 5 years ago, something like that, when I first came in and did our big major edit. We updated that guideline so that it actually had a lot of these newer philosophies already built into it. So honestly, there's really no change in the guideline. We might change a little bit of wording in our 2020 guideline just to be a little bit more consistent with some of the vernacular that's being utilized across the country. But overall, the principles are the same. So no, in some there hasn't.
Okay, well, that's good to know. So there has been some recent evidence that came out, though, that might have altered what we think about our existing guideline, though, right?
Yeah, so you're absolutely right. That I think that we can kind of look at our guidelines a little bit more carefully and interpret them a little bit differently, and that's where a new position statement came out. And I'll actually go ahead and share that with you guys. Let's see. All right, hopefully everyone can see this. So this was a position statement that was put out by the National Association of EMS Physicians, the American College of Emergency Physicians, and the American College of Surgeons Committee on Trauma. So honestly, these are like the big player organizations that actually tackle what we do and really help to provide guidance. And to get all these folks on the same page, this took over 3 years. It took over 30 drafts to get this to where it is now. And it was released late in 2018. And we're really kind of excited to have this, at least as the EMS community is really excited to have finally everyone on the same page, so that when you do roll into an emergency department, having done care that we've considered acceptable for the last 5 years, but that some of these community emergency departments may not be up to date on the last 10 years worth of literature, you can easily say, hey, no, your specialty organizations really supported this. So I wanted to take a couple of minutes, and we can kind of use this as a tool to frame this discussion. So I'm going to go through this a little bit. This is, again, the spinal motion restriction in the trauma patient, a joint position statement by all these guys. I'll skip over a lot of kind of the fluff here, but they bring out a couple of points of consensus. I think the first one is pretty understandable, that the unstable spinal column injuries can progress to severe neurological injuries in the presence of excessive movement of the injured spine. This is exactly what we've been talking about for a very long time. This is why we've, in the past, quote unquote, spinally immobilized patients. It's because we're worried that moving around people with spinal fractures can be bad for them, neurologically speaking. That's a pretty easy point of consensus. Number two, while current techniques limit or reduce the undesired motion of the spine, they do not provide true spinal immobilization. And that's why we're calling it spinal motion restriction moving forward. So I would welcome you to recognize that, when you put a patient on a backboard and with a headbed and immobilize them with webbing, now that's not magic. They're not suddenly completely incapable of moving their spine. I think we all recognize this when, we've got somebody in that position and they start to vomit and we roll them over onto their side. Being restrained to a backboard and a headbed with webbing, et cetera, they don't suddenly not move at all. They do slide, and really it's not true spinal mobilization, it's spinal motion restriction. So I think in our guidelines, we've always referred to it as spinal restriction. We might, in the 2020 update, change that to spinal motion restriction, since that seems to be the more favorable name. So I would recommend that you, in communicating with your friends, in documenting patient reports, stop using the term spinal immobilization and start moving towards this concept of spinal motion restriction, which is more in line with what's actually happening. Point number 3 here is that while backboards have historically been used to attempt spinal immobilization, spinal motion restriction may also be achieved by the use of a scoop stretcher, a vacuum splint, an ambulance cot, or other similar device to which a patient can be safely secured. And I think that is a big step forward in the world of spinal motion restriction, that for these agencies to get together and say, the backboard is not the only thing. You have options. You can use that scoop stretcher. You can just place them and secure them to the ambulance stretcher, the cot itself. That gives you some options. So and I think maybe now is a good time to kind of discuss a little bit about when you might use certain devices. So I think that as a whole, and we were talking a little bit about this before we started recording here, is really, when do you use a backboard? Is it inappropriate to use a backboard? No, I think it's still completely appropriate to use a backboard and to do the full meal deal of putting them on webbing and with a headbed and the bolsters, the rolls, and to tape their head down. I think that's still completely appropriate. I would not yell at you for doing that by any stretch. And I think that there are certain patient populations where I'd say that that's probably one of the easiest things that we can do. So when might I do that? In that patient who truly does have the sign of neurological injury. So they just fell and they can't feel their lower extremities or move their lower extremities. That's pretty concerning to me. I think that it's perfectly acceptable to do the full meal deal and put them on a backboard. I think for those critically ill trauma patients that you just pulled, they were just ejected out of a motor vehicle collision, and now they have a head injury. You're already planning to intubate these folks. Those are definitely folks that I would would be more than happy to have on a backboard, just really mostly to facilitate their movement and really make it a little bit easier. It's when you start getting to the ones that are the low mechanism motor vehicle collisions, the ones that just have a little bit of neck pain, that kind of thing, or the ones that have neck and back pain after a motor vehicle collision. I think this is where you start saying, do I really need to completely secure them to a backboard, knowing that when we get to the hospital, it might take them a fair amount of time to sit on the wall and actually get cleared into a room, et cetera. And that's where you start weighing the risks and benefits. This is all a risk-benefit game. You start realizing that backboards are not without risk. I mean, if you sit on backboards for long enough, yeah, you can get ulcers, but also, if you take a 70-year-old person, put them on a backboard, after about 5 to 10 minutes, they're going to have back pain from being on that backboard. And what's the downstream effect of that is that the ER is not going to be able to say, okay, now that you've got this back pain, I think it's because it's the backboard. We're not going to do any imaging, et cetera. No, they're going to image that person. They're going to expose them to extra radiation. They're going to end up, costing this patient more money in imaging. So there are some actual risks of using the traditional backboard. Which is why they're really kind of pushing this option of saying that, if you want to use a scoop stretcher, you can use a scoop stretcher, get that older lady off the floor, put her on the on your ambulance cot and remove the scoop stretcher. Or Shevis, as you mentioned, you want to talk about a little bit about your thoughts on kind of the ambulance wall times and how you would interpret this?
Yeah, I was listening to what you're talking about and just thinking about this earlier, I think we've got a couple of different scenarios. First off, just to recap, there's your critical trauma patient scenario, which I don't think for anybody is a surprise that in blunt critical trauma, they're likely going to be on a backboard, fully immobilized, ready to go. I think that's pretty reasonable. The minor patient is what seems to be a little bit more confounding. So I kind of have this set up in 3 different scenarios. First, there's the short transport time with no expected wait. In those cases, it seems like it might be a little bit more work than is necessary to put someone on a device, then take them off the device to go 5 or 10 minutes down the road to put them back on a device to facilitate moving them over. So in those cases, it seems to me, at least, to make sense to keep them on the device if you know that you have a short transport and no expected wait. Then there's the scenario of where you have a short transport, but you have a long expected wait. In that scenario, if you walk in the ER and they say, hey guys, we're having a hard time turning over beds and you might be here for a bit waiting, and you have a stable patient that's not demonstrating any sort of neurologic dysfunction or anything like that, it makes sense for their comfort to go ahead and take them off the device. And oftentimes that's going to be facilitated by the emergency department staff that's there anyway. They want to get the patient off the devices as fast as we do. So I don't think you're likely going to have a lot of heartache from the facility about removing them from the device, especially if they have a chance to come and kind of pre-screen the patient. And then there's the stable transport that's going to occur over a long period of time, is I guess our third scenario. And if you know that you're going to take a patient a lot farther than where we would ordinarily transport, and they're what you calculate as kind of low risk, it seems reasonable to me to take them off the backboard or the scoop stretcher and leave the cervical collar in place. Seems to be reasonable. Sam and Jen, what do you think about that? And would you do anything different in your clinical practice?
I'll let Jen answer first.
I think that's a good thought process, Chavez. I would agree with everything you just said on your theories on long transport times, long hospital waits. I'm totally in agreement with it.
And I would second that. The one thing is also important as the crew and you're managing the patient, kind of what your gestalt is. If some of these variables, we don't know all of the variables, but if you feel like they should be have spinal motion restriction implemented, then do it. There's nothing to say that you shouldn't do it, or even those patients that may have a low mechanism. If your gut instinct is telling you that there may be something wrong, you could certainly put them on a stretcher with the C-collar, just to make sure that the documentation kind of reflected why you did so.
And I'm going to jump in the document a little bit, and let me get this back up on the screen here for you. But I'm going to jump in the document a little bit, and I'll come back to when we would restrict somebody. But I think a couple of key things here about that, what Chavez was talking about, that all patient transfers create the potential for unwanted displacement of an unstable spinal injury. And particular attention should be focused on patient transfers from one surface to another. So as they make a mention, from like the ground to the ambulance cot. And that's where a long spine board, a scoop stretcher, a vacuum mattress is really recommended to assist with patient transfers in order to minimize that flexion, the extension, the rotation of the possibly injured spine. So for me, what that means is that if you've got that little old lady with the hip fracture on the ground, maybe the scoop stretcher is the easiest way to get that patient from the ground to the ambulance cot. And I want you to recognize that a scoop stretcher is an appropriate mechanism by which you can do that. And if you want to keep them on the scoop stretcher, you can keep them on the scoop stretcher for the duration of the ride, as long as they're securely in place. If you want to remove them from the scoop stretcher and keep them on the ambulance cot, that's perfectly acceptable too. So just recognize that you've got some options for how you can appropriately motion restrict somebody. Item number 7 here is that once a patient is safely positioned on an ambulance cot, transfer or extrication devices may be removed if an adequate number of trained personnel are present to minimize unnecessary movement during the removal process. And that's, again, exactly what we said, that if you want to, if you're in Chavez's position and you are at the hospital, let's say, and you're going to be sitting on the wall for a while, and you have an adequate number of personnel to appropriately log roll the patient and remove the backboard or whatever device that you're using, then that's great. Let's say that you already know that the hospital is going to be busy, and you've got enough firefighters on scene to adequately remove a patient from whatever extrication device, and you just want to keep them on the ambulance cot. That's an acceptable thing too. You just need to be able to safely remove them from whatever device you're talking about if you plan to remove it. So it also says the risk. Oh, go ahead.
Oh, I was just going to tag on that, and that kind of leads you to think that a lot of times maybe a scoop stretcher would be a better choice when you do have to move those patients, because it's easier to remove the scoop stretcher than necessarily log rolling and pulling the board out, unless you had lots of personnel and fire department to do that to help.
That's a really good point. And it says here that the risks of patient manipulation must be weighed against the benefits of the device removal. And that's where we jump into exactly what Sheva said, that if the transport time is expected to be short, it may be better to transport a patient on the device and remove it once you've arrived at the hospital. If the decision is made to remove that extrication device in the field, then obviously you need to make sure that you're appropriately restricting that patient's spine movement, keeping them in that C-collar, and appropriately securing them to the ambulance cot. The last point here, point 8 in the subject matter, is that hospitals should be prepared. Let me get that a little higher in your screen. Hospitals should be prepared and equipped to carefully and quickly remove patients from a long backboard, a scoop stretcher, or not in our case, a vacuum mattress, as soon as possible after their arrival at the hospital. And that safe transfer may require the use of a slider board or similar device in order to maintain spinal motion restriction during that patient movement. Procedures should be in place to assure that a sufficient number of properly trained individuals are available to assist with patient transfers in order to minimize the risk of inadvertent displacement of a potentially unstable spinal injury. So, Sheva, can you give us a little bit of insight as to the availability of slider boards and what we're doing internally to help with that?
Sure. So at most hospitals, at least, they're supposed to have one of those white, thin radiology slide boards. And if you're close to an ER that's immediately proximal to radiology, either one is probably in the room that you're going to be in or close by if you just ask someone to fetch one. What we're trying to do here at HCEC is to see if we can find a vendor of a slide board that'll fit within the dimensions of our striker cot and go underneath the mattress. And so that way, if you think you're going to need a slide board, you'll have one available to you. And obviously, you'd need to take it out before you put your patient on the board and put them on the stretcher. But you would have access to that slider board, and we're working on that solution right now. So either something that we'll engineer at home with the help of our infrastructure team, or something that we can find that's commercially available. Either one, I think, would be good. And that will really help out and getting the patient moved over without compromising their spine.
And the hospital should have those. And I think that this language, again, being supported by so many different organizations, is language that we can take to those hospitals to really advocate for them to purchase this and have them available, at least in their offloading areas. And so we're going to work with them to make sure that happens too.
I'll tell you, in my experience, it's pretty rare for a radiology suite not to have one. They typically always have one in the ER. It's ideal. But I know if we arrived at an ER and they didn't have one, if you have a radiology suite somewhere, I'll feel pretty confident they'd have one.
Yeah, it's usually pretty standard in the trauma suites, at least in a couple of the medical center facilities and at Houston Northwest that I've seen them in the department.
So don't be afraid to ask for them. The more you ask for them, the more that they're going to have them available as well. So, I think gone are the days where we try to do two people carrying somebody up by a bed sheet as they're bent in the middle, dragging them over across the bed, ruining our backs, ruining the patient's fracture. Those are things that we should be trying to save our backs. We should be trying to do the best thing for the patient too, and make sure that we slide that patient on a slider board. It's a heck of a lot easier.
I completely agree. Now, I know we had done some work before we had planned this session, and we had asked the field supervisor group to craft a question that they thought might come up in our conversation today about the use of our selective spinal motion restriction guideline. And I think Jen has the list of compiled questions, and she's going to ask some of those questions, and then we're going to see if we can all gain consensus on some of the answers. So go ahead.
Great.
Okay, you guys are ready? All right, so if a patient meets SMR criteria and a C-collar is placed on the patient, must the patient stay in a flat, neutral position for the remainder of the time in EMS care?
That's an awesome question, and that's one that is certainly the one that's like the hot button issue that we're all talking about. And why this? And I think I've changed my mindset a little bit on this. I've started to realize that this document is great. It's the one that we're going to be held against, and if you interpret it in a certain way, then it can still match what I would say 99% of emergency physicians do in their daily practice. So I just want to share with you the bullet point that makes a little bit of consternation here. It's item number 5. The spinal motion restriction, when indicated, should apply to the entire spine due to the risk of non-contiguous injuries. What are non-contiguous injuries? They're essentially when you have a spinal fracture in one part of the body and in a completely other part, in one part of the spine, and then a completely other part of the spine that's not right next to it, non-contiguous, you may have another spinal injury. Now, ATLS, the Advanced Trauma Life Support course, their textbook says, at least off of the information that they've been able to bring up, that up to 10%, so 1 in 10 patients with a cervical spine injury also have an injury in the spine somewhere else, like in the thoracic spine or in the lumbar spine. That's a pretty high number. I mean, you have to remember again that just over half, about 55% of patients with spine injuries, their spine injuries are in their cervical spinal area. Another 45, so just under 0.5%, have them in either the thoracic spine, the lumbar spine, or that thoracolumbar junction. So I know we always talk about cervical spine, but you have to remember that the spine doesn't end at C7. It continues down, and we can't ignore the rest of the spine. So when they make this point that spinal motion restriction, when indicated, should apply to the entire spine, and what that means is that you have to essentially put them in a C-collar and keep them completely flat. The way that I interpret this is as follows, and I'm going to take it off the screen so that at least I can get bigger here. So the way that I interpret it is that if you have a reliable exam, so if you are completely alert and oriented, if you are not intoxicated, if you don't have a distracting injury, so you have a completely reliable exam, and you have no neurological red flags, no motor deficits, no sensation deficits, and that's the perfect patient that we are now capable of appropriately deciding whether this patient may not need a C-collar or any type of spinal motion restriction. So that's the patient that we go and we feel every single vertebrae in their neck. And if they don't have any neck pain, we typically don't put them in a C-collar. What I challenge you to do is to continue and feel every single one of the vertebrae in their thoracic spine and in their lumbar spine. Because again, up to just shy of half of these patients may have just a thoracolumbar fracture and not a cervical neck fracture. So where I go with this is that if I palpate somebody's neck, again, they've got a reliable exam, no neurological findings. I palpate their neck and, oh man, I can't clear them because they have neck pain. And I continue and I palpate. I don't do that like simple, I'm going to run my finger down their spine. I'm going to actually touch. I'm going to palpate every single one. I'm going to give them a great physical exam. I'm going to palpate every single vertebrae. And I don't feel, they express no pain, no tenderness. I feel no deformities. Everything looks fine with the rest of their thoracic and their lumbar spine. Then I feel comfortable that I'm not going to have to image them in the hospital. I don't think that they have a thoracolumbar fracture. I think that, the only concern that I have is up here in the cervical neck, is up in the neck area and that cervical spine area. And that's where I feel comfortable putting them on a C-collar and letting them sit in a position of comfort at that point in time. What that means mostly to me is that we probably prop them up about 20, 30 degrees. We don't need to sit them completely up at 90 degrees. I mean, I think that 20 or 30 degrees is reasonably appropriate. Where we run into problems is that we walk in, and where I've seen this on scenes is that we'll walk in, we'll only feel the back of the neck, and of course they're assuming that they're mentally, it's a reliable exam and they have no neurological deficits. We'll palpate their neck and we say, okay, great, they can do whatever they want. And we completely forget about the fact that we really need to do an exam on the thoracic and the lumbar spine. Because I've definitely seen us where we take patients with thoracic back pain and we let them sit upright, and that's not right. We need to appropriately restrict the motion of that part of the spine. So what that means to me is that if you're putting a C-collar on a patient who's got a reliable exam and they have no lower back pain, no thoracic back pain, then I'm okay putting them in that more seated position of comfort. If they have back pain, whether they have neck pain or not, they need to be flat. You need to consider that they might have a thoracolumbar fracture.
Hey, Dr. Decker?
Yeah.
And then maybe this is a good question for you and for Sam, since Sam coordinates ATLS. is there a particular subset of patients that are more at risk for non-contiguous injury?
That's a good question. I'd have to actually do some research on that. I would tell you, I've heard the 10% number thrown out for the last 20 years. So that data probably is pretty old. I don't know if it's still been validated, but I don't know. I would have to do some research to really get a good answer.
I mean, I have to think about patients that might have maybe a high axial load or something like that could probably be at risk. But really, I guess any blunt trauma patient that has high forces could be at risk, theoretically, at least, for non-contiguous fracture. What do you think, Dr. Decker?
Yeah, so I think that underlines exactly what you're saying there, Chevis, that if they have that midline neck pain, really, especially if you're concerned about a fracture, really consider that you've got a 1 in 10 chance based off of the macro data. You've got a 1 in 10 chance of them also having a thoracic or a lumbar fracture. So I think that data that's been in that ATLS text, I'm sure, as Sam mentioned, it's probably old, and I think it's actually rather large, more like a registry data kind of set, and it really doesn't tell us, did that patient have back pain? Did they not have back pain along with their cervical neck pain? What was the story there? But that should make you concerned that some of these patients can have more than one fracture, and so if they have neck pain, really just do a good physical exam. Be concerned about that.
Right, because I do know. It might not necessarily even be in the thorax. It could be just another cervical injury at C3, C4, or C7, but they're just not continuous. So again, it could just still be related to the neck.
Yeah. Now that's kind of one patient population, but I want to make reference to the other big elephant in the room here, that if you're interacting with a patient that does not have a reliable exam, so they are unconscious, they're altered, they're intoxicated, they've been smoking weed, they've been drinking a lot of alcohol, or they have that distracting femur fracture. Those are patients that you can't get a reliable exam in. And those are patients where you have to assume that they could have a cervical spine fracture or a thoracic or a lumbar fracture. So in those patients, they need to be flat. You need to keep those folks flat. And that's where you do the full spine component, where you're concerned about that. The same kind of thing that if you've got a neurological deficit in these patients, they need to be flat. You can't let the guy who is intoxicated, who was just hit by a Mack truck, you can't let them sit on the stretcher. You've got to keep them flat.
That makes good sense. So Jen, what's the next question you have on your list?
Okay, so the next one is there still a use for a KED on the ambulance?
So I'm going to take an informal poll here. I'm curious. So who has used a KED in an adult in the last 15 years? Show of hands. Right. Okay, good. All right. So I think we're on the same page. So the KED is an as the name, it's a Kendrick extrication device. I think that there is value. Well, no, DSHS thinks that there's value in keeping one on our ambulances. I think that there might be the patient population that you'd want to use the tool to help get somebody out of the setting that they're in. I mean, the last time that I used it over 15 years ago was in a kid who dove headfirst into an above ground pool and definitely had a cervical spine fracture. And we just found it relatively challenging to get him onto a backboard and in that whole situation. And he was alert and talking with us. And so we put him in a KED, and then we're able to better get him maneuvered onto a backboard and then out of the water and down the pool, et cetera. So I think that there are some patient populations where that gives you a little bit of extra support and a little bit of extra comfort on your end. And of course we sometimes use it with pediatric patients as well. But
I think we use it mainly with pediatric patients is what it seems like.
And I would agree. That's the time to use it.
There's 1 in 200 times of where you've got someone really difficult to get out of a vehicle that you can put the KED on and maybe help facilitate moving someone out of a car. But yeah, the KED, it's tough. All right, what's next, Jen?
If the crew is using a backboard to move the patient to the stretcher that has a C-collar on, can we use duct tape to secure the patient to the board or cot safely?
I defer to Chevis on this one.
So if you look practically, and you have a patient that's not nauseated, that they're low risk, and all those things, it probably doesn't really matter if you use duct tape or not. However, if you're clairvoyant and you know that your patient's not going to vomit, it's great. However, a lot of times in transport to the hospital, especially in a patient that has any kind of head trauma, they're looking up at the ceiling and they can't see where they're going. And it's easy for them to become nauseated. And if they actually vomit and now you have to turn them on their side, then you're not going to always have reliable immobilization with duct tape. It gets trapped with grass or debris before you tape it down. Sometimes the surfaces underneath the backboard are slick, so it doesn't always want to grab hold, especially if there's any humidity in the air. And so unless you go all the way around the backboard with the tape, it doesn't reliably restrain the patient. And it's actually not on our equipment list anymore. So if you find duct tape on your truck, it was either brought from home or it's a remnant from a long, long time ago, but it's not really appropriate for spinal immobilization.
I would agree with Chevis. I think, obviously I can't say always, but that should be a last resort for securing an inpatient. Maybe that'd be a mass casualty incident where a fire department had it available, but it really should be a last resort.
Thank you.
All right, Jen, what else do you have on your list?
The next one is, how does the spinal motion restriction guideline apply to a football player that has an injured spine and a helmet in place?
Oh, I think Sam would do a great job with this question.
Well, the idea is, again, you are complicated because you do have a football player with a helmet. Really, in your assessment, if you're concerned about a spinal injury or neurologic deficit, then obviously you would want to immobilize them. You definitely would want to assess their airway because that's the biggest factor in deciding, do I keep the helmet on or take it off and then immobilize them? But you'd really want to do a really thorough airway assessment and really speak to your patient. Is he unconscious? Are you worried about a head injury as well? Because those patients can be at high risk for airway compromise if you immobilize them with the football uniform and their helmet on. If you do remove that helmet, you do need to recognize if they have their shoulder pads still on, then you really do need to do some additional padding to adjust it. Because ideally, we'd like to have have them completely supine on that board where there's no dipping, because now they have the shoulder pads on, but their head's falling back and it's causing them to flex their head. So it is a complicated situation. However, really assessing the airway is going to be key when you decide if you're going to keep them immobilized or not.
Yeah, I always think about motorcycles versus folks in football gear. The guy on the motorcycle needs to have their helmet removed so that they have neutral spinal alignment. And just the design of football pads and helmets allows you to leave the helmet and pads in place and just take off the face mask, which is a really nice way to keep the patient in neutral alignment. And if you, for whatever reason, need to get access to their chest, you can cut off the pads from the chest, and that way you can cut them out to be able to see the chest and address anything that's on the thorax.
I think the old mantra is correct that if the helmet comes off, the pads have to come off. And if the pads come off, the helmet has to come off. But you can adequately typically manage the football player by keeping the helmet and pads on and using your athletic trainers who are working these events with you to remove that face guard. And I think obviously the NFL has their own kind of way of dealing with it. The Texans certainly do. Each major sports team does. I have a feeling that a lot of the athletic trainers will probably be looking towards you on the smaller high school games and things like that to manage those patients. But definitely, if one comes off, the other has to come off. So if the helmet comes off, the pads have to come off. And you have to, and at that point, again, same kind of story. Once you've gotten this stuff off, or even with it on, you can use a scoop stretcher, you can use a backboard. Once you've gotten all this stuff off, if you want to secure them on the ambulance cot appropriately, then that's great too. But all that's really heavy equipment, and you want to make sure that they're not hyperextended or hyperflexed or hyperextended at that point too.
All right, Jen, what's next?
So do we use a headbed if we're using the stretcher cot only?
Great question. Okay, so here's my thought process on that. Short answer, probably not. So how at least in an informal poll of a lot of other medical directors, and just kind of looking at the mechanics of this, that if you put somebody on a backboard, that's a relatively slick surface. They potentially might slide. I think it's appropriate to appropriately web them with a good C-collar, appropriately web them, and then to use a headbed and the rolls and get them completely down, the full meal deal. If you put somebody just on the stretcher, I think that using the seat belt straps, again, the ones that go across, as well as the shoulder harnesses, I think that's, along with the C-collar, an appropriately sized C-collar, I think that's all you really need. Now, if you're going to, if let's say the patient is intoxicated and they're agitated and they're moving around a lot, then yeah, you might want to put some bolsters there and you might want to tape their head down. If you just picked them up from, a mile into a construction site and you're having to go through the largest potholes or the ones that used to be on JFK, then I think that's a reasonable thing too, that if they're moving around a lot in the back of the ambulance, maybe. But if you can tell your driver, hey, slow down and give this person a smoother ride, most of the time there's enough friction in that whole process, and an appropriately sized C-collar, you generally don't need to do anything else. A little side tidbit though that I've noticed that drove me nuts is that I've noticed that historically, sometimes, not all the time, thank God, but sometimes people would secure the head before they actually secured the torso on a backboard. And that drove me nuts because, again, if you're worried about vomiting or whatnot and you start rolling this patient, the only thing that's secured is their head, and now their body sloughs off to the side. So again, it has to be torso secured. The last thing that you are going to secure, if you're going to secure it, is going to be the head at that point.
I see a theme occurring here with this appropriate size C-collar.
Yeah, that's true. That's true. An appropriately sized C-collar is key. That certainly helps. And if we want to take this discussion into into the scoop stretcher, if you want to pick somebody up on a scoop stretcher and keep them on a scoop stretcher, I think for the most part, there's enough concavity in the device that if you've got an appropriately sized seat-collar, if you've seat-belted them to the device appropriately, and if you don't have excessive movement in the back of the ambulance going through that construction zone, weaving in and out of traffic, you probably don't need to secure somebody down with a headbed at that point in time either. However, if they're agitated, if they're moving around, if you do get a lot of excessive movement, or you suspect that there might be a lot of excessive movement, there's no harm, no foul in putting the headbed down there, as long as they've got the appropriate heading and bolstering it up, or just taping them across. I'll tell you, most of the time in the emergency department, we don't tape anybody down to the bed. I mean, it's not something that we do. If they're moving around a lot and I'm concerned about a cervical spine injury and they're intoxicated, if I don't just sedate them, intubate them, then I might tape them down. But for the most part, a lot of these patients don't need to be secured down to a surface that has enough friction, as long as they're wearing an appropriately sized C-collar. Does that make sense, at least?
I'm going to add to that question because this kind of goes hand in hand. So we also have a patient with midline neck tenderness from pain from a fall, who has a C-collar in place and are laying flat on the cot and secured with the stretcher straps. What should we do if they begin to vomit?
Man, that's just a bad day. I think ultimately this is where we kind of look at it in a grander spectrum of risk-benefit analysis. That the risk of them aspirating is much higher in that setting than the risk of them than the risk of you in a hasty maneuver trying to roll them while also maintaining cervical spine immobilization, or some sort of cervical spine motion restriction. That risk is going to be a lot more in the aspiration column. So obviously, it's important to get them rolled. I think that while sometimes those are completely unplanned events, I think that there are times in which you have to be thinking about that down the road. So if you're dealing with a patient who is obviously intoxicated, who just came out of a bad wreck, who probably has a head injury, I would probably put them on a backboard and immobilize them that way, especially if I'm alone in the back of the ambulance. But recognize one thing, that backboard and headbed, again, are not magic. They're not going to completely immobilize that patient altogether. When you rotate them and you roll that backboard, you really all know that they slide a little bit, no matter how tight you think you've got that webbing. It's not a perfect thing. So I would say that there's that component, that you should probably do a good device selection if you anticipate them vomiting. You also, part of that preparing piece is that you probably should have the thought, should I bring a firefighter with me? Should I have that student sit in the back? That kind of thing. So having that extra hand, I think 2 people can adequately roll somebody. Making sure that you've got suction available, making sure that you use antiemetics when you think that there's going to be a need for it. But again, if you really think that they're low risk for vomiting on you, and hey, you were surprised, you're surprised, and that's okay. And we understand that, and you'll do the best that you can to maintain that neutral spinal alignment. But at the same time, backboarding people has risks. I mean, a kid putting that 70-year-old patient on the backboard and they suddenly develop back pain 5 minutes after you put them on that, because it's a hard, unpleasant piece of plastic. That person's going to get more radiation. That person's going to get a higher bill. They're going to get, more time in the emergency department. It's just going to be there's a risk associated with all these things. So you got to really kind of weigh it all and decide. And so what I would recommend that you do is that in your documentation, you articulate why you chose one route versus the other, why you had to do what you did. And overall, you treat the patient as individuals. You can't just paint it black and white and say everybody gets a backboard, period.
Right, I would agree. I think that key point in regard to that, if you have a patient you think is at high risk, is getting the fire department to put maybe 2 firemen with you. Just additional help for that anticipated risk would certainly help potentially alleviate that.
All right. Last question. Oh,
We're ready.
okay. I thought I lost you for a second. Okay.
We're still here.
Would SMR be appropriate or indicated in patients with penetrating trauma that have secondary injuries?
Great question. So I'm gonna briefly bring us back to the document here that has item number 8. There's no role for spinal motion restriction in penetrating trauma. That's the only phrase that is slightly different from our guidelines. Our guidelines actually state, zoom in here, patients with penetrating injury to the head, neck, or torso and no evidence of spinal injury should not receive spinal restriction. So here's how I would view this. In the pure isolated penetrating trauma, there is an exceedingly low risk of having some sort of spinal trauma. Did I say that right?
Yes.
Yeah, exactly. So an exceedingly low risk of spinal trauma in patients that have pure penetrating mechanism. And how I would say that is that if you had no neurological deficits, I'd let you sit up without a C-collar all day long. I'd put you in a position of comfort. Putting on that C-collar, that's a risk in and itself. Having them lie on their back, that's a risk in and of itself. You could cause respiratory depression or respiratory compromise. You can maybe not see that expanding hematoma. Maybe you've got a point where you don't recognize that your landmarks are suddenly disappearing for that surgical crike that you thought you might need to do. You don't need a C-collar in most of those patients. Would I say that if I ran across a patient who had a penetrating abdominal or chest wound and then suddenly had no feeling below the level of their umbilicus, that's where I would gingerly manage them. I would probably put them in log roll precautions in that spinal motion restriction kind of approach. I don't know if I can dive in 100% on the line that there is no role for spinal motion restriction in penetrating trauma. If you have obvious neurological deficits, I don't think I'm going to throw you over my shoulder and put you in the back of the ambulance. I think I'm probably going to be a little bit more ginger with you. So,
are you saying we have to use judgment?
Probably a little bit of judgment. Yeah. So if I would say that if you've got neurological deficits, I would somewhat motion restrict you.
But I will add to that. So I anticipated this question, and I reached out to medical directors at the level 1 trauma centers, and I reached out to 3 different individuals, and all 3 of them said, really, you do need to use judgment. However, if you came in with spinal motion restriction, recognizing that there was a neurological deficit, they were shot, they would be happy with that. And if you happen not to, they'd be happy with that as well. But they did say, really, it's really that judgment that you have to decide the risk benefit for that patient that might have had a penetrating trauma.
Now, to answer the question that you asked a little bit more carefully here about secondary injuries, if you were on top of your house and you pointed a gun at police and police shot you and you fell to the ground, off the roof of your house, yeah, I would do spinal motion restriction. I would definitely treat you appropriately. So just because, I mean, it's the same kind of concept that, the guy that you can have a medical cardiac arrest in a motor vehicle collision all at the same time. You can have blunt trauma as well as penetrating trauma in these patients. So don't let your brain shut off the only time that you see the bullet hole. Think about what happened to that patient afterwards or prior to that incident. So yeah, that's how I would answer that question, is use your brain.
Awesome. So Dr. Decker, if you had to do a 30-second summation of what we've talked about today, what are the succinct points that you want people to walk away with?
I would say that you've got tools. You've got more than just a backboard. You should now feel comfortable with the idea that you can perform appropriate spinal motion restriction on a patient when it's indicated by using that backboard, by using that scoop, or by appropriately securing them to the stretcher. Again, all with an appropriately fitting cervical collar. And then the other point that I would make, just so that we can get through some of this mess, is that if you've got a patient with a reliable exam, a reliable patient who you really feel that they've got a reliable exam and no neurological deficits, if they've got back pain, they need to be flat. If they've got neck pain and neck pain only, then they can probably be in a position of comfort. If they don't have a reliable exam, or if they have neurological deficits, you need to assume that they could have non-contiguous, i.e. cervical and thoracic or lumbar or multi-level cervical spine injury, and you need to completely keep those folks flat and motion restricted. That's what, and I guess the third point, open the darn article up for yourself. Type in NAMSP, National Association of EMS Physicians, and spinal motion restriction consensus and into Google, and it'll be the first 30 results. You will find it, and read this thing on your own and see what they're telling you. They've got a whole section of spinal motion restriction in children that we didn't talk about here, but that it's valuable and is in line with our guidelines. So read this document as well.
Awesome.
I just wanted to add a statement, and really recognizing that our policy really has not changed. Our protocol hasn't changed. We are going to address it. It speaks to the innovation that Harris County has, that this statement came out in April of 2018. Our protocols were 2014, 2015, and our policy really hasn't changed. So our approach has been scientifically evidenced that we had a great approach, which speaks to the fact that you are a medical director and with Chev is leading, clinical services. We were on the right page.
This is the biggest step in spinal motion restriction discussion that has been a consensus applied agreement in 40 plus years. I mean, this is a huge step of finally saying, hey, there's evidence out there that we should probably look at and not just do voodoo medicine here.
Right.
That's great. So a couple of things as we wrap up is, one, I think we'll post links for the NAEMSP consensus article, and we'll also post the link to our current spinal motion restriction guideline for you guys to be able to review. The other thing I'd recommend is, don't forget there'll be some practice or some test questions at the end for you guys to take so that we can generate CE for you. So please do your exam, and then at the end you'll also have an opportunity to give us some feedback. And I'm curious to know what you thought about today's format for future discussions. And if you liked what we did today and you thought there was value in this, please let us know in the comments that you enjoyed the session. And then I also want to thank Jen for agreeing to be with us on her day off. She's been playing mom on the side with her baby in the background. So thanks again for hanging out with us on your day off. And if you guys don't have any other final comments, then I think we're going to close for today, and we'll see you next time.
Thank you, guys.
That's great.
All right, thanks.